incredibly rapid. All right. So I've clicked the go live button and we are live, even though that will take a little while to come through to the website. So hello, everyone. Thank you so much for coming along to this special event. My name's Chris Groot, and I'm an academic at the Melbourne School of Psychological Sciences. And I think many of you will already know me. You're probably quite a few students out there as well. And I've been joined today, we're all lucky to be joined today by Simon Katterl, who is an alumnus of the Melbourne School of Psychological Sciences at the University of Melbourne. We can see some people saying hello in the chat, which is wonderful. Hello, everyone. Paul, Hamish, Amy, Rita, thank you so much for tuning in. So, say hi, Simon. Yeah, say hi.
Yeah.
I'll introduce Simon in just a moment, but I did want to start the stream by acknowledging that, of course, even though we're in a virtual space right now, we are indeed streaming from for Simon, Wurundjeri land, and for myself out here in the Bellarine Peninsula, Wadawurrung land, and would like to acknowledge that and pay our respects to elders past, present, and emerging, and acknowledge this land was never ceded. So I imagine there's people joining us from all over Australia, and if you are and you'd like to acknowledge the land from which you're tuning in from, also feel free to put that in the chat channel. Looks like my camera is having a moment. Let's hope it holds in there. So everyone, thank you so much for joining Simon and I. I think this is going to be a really interesting opportunity for us to pick Simon's brain. As I said, he's an alumnus of the School of Psychological Sciences, and he completed a graduate diploma in psychological science here. And indeed, we've got many grad dip students working hard in our summer intensive program right now, where they're doing all of first year psychology in 6 weeks. And Simon, you survived that previously.
I don't know if they still have it, but I remember the first day was we got straight into neuroscience, and we were just bludgeoned with neuroscience on that first day, and I thought, what am I getting myself into? But it was great. It was great. It's a steep learning curve, but I enjoyed it.
We certainly still do bludgeon with neuroscience whenever possible.
That's good. That's good.
So for everybody who doesn't know Simon, let me introduce him a little bit further. So Simon, in addition to having a graduate diploma, has done further studies in law and in political science. He's worked as a mental health peer advocate. He's worked in regulatory settings and policy and consultant roles at the Victorian Mental Illness Awareness Council, VMIAC, and in independent mental health advocacy, Victorian legal aid, the Mental Health Complaints Commission, the Equal Opportunity. What a long and very impressive CV this is. The Victorian Equal Opportunity and Human Rights Commission, the Royal Commission into the Victorian mental health system. An amazing set of accomplishments in such a small amount of time, because I can remember Simon as a third-year student in the program.
So and what shows how good a graduate diploma in psychology from Uni Melbourne is, huh?
Yeah, there you go. So Simon's done a lot of work around addressing discrimination and human rights, and does a lot of work around powerlessness within the mental health system, and is very passionate about improving mental health and well-being. And I think the system, certainly generally speaking. So Simon, thank you very much for joining me today with this chat, and it's great to see that so many people are joining us. Nearly 50 people out there already, and apparently we've got some disconnection between my audio and video, but hopefully that will correct itself at some point. We're doing okay nonetheless. I did mention to Simon just before we went live that my computer sounds like it's about to take off like an aircraft right now. It's running hot, processing all of this video, so that's okay.
Yeah.
So, Simon, it's been a really interesting journey to from a member of faculty, from the perspective of a member of faculty, to watch your journey and to see you grow from, I think we touched base. I think you came up to me after a lecture really early in
Right near
the start of the psychopathology of everyday life subject, and we got talking, and I think you were already working maybe with Vimiac then.
I was about then, yeah.
So maybe if we think back to the start of and obviously your journey started even before that, maybe a great place to start would be to speak a little about what attracted you to psychology, why you became interested in that and took on the grad dip.
Yeah, absolutely. So as I think you mentioned, I studied law and international relations prior to psychology. So I was doing that in Brisbane, and then I worked overseas for a little while in East Timor. And I think the kind of culmination of working over in East Timor, and then also some early childhood experiences and challenges, kind of led me to have a bit of an emotional breakdown myself. And that's where I guess I had a connection to mental health issues. And so, I kind of, when that happened, I sort of knew I wanted to work in a social justice space, but it really clarified that I want to do that in mental health. So I moved down to Melbourne. I started the grad dip in psychology, and I really enjoyed that. It was a really good opportunity to learn a whole set of skills that you definitely don't get doing law or politics, which are also really important skills, but really different and really valuable set of skills that kind of drew me to that.
So, well, that's quite a paradigm shift from all of those experiences to extended servitude in the Redmond Barry building.
That's right. Yeah, that is right. Yeah, it was a bit of a different pathway, but I mean, I think a lot of people, so identify as having lived experience of mental health problems and being part of what we call the consumer workforce, and I think that's a kind of pathway a lot of people find themselves coming to mental health in, is their lived experiences in whatever forms they are, are usually quite diverse, but they lead people to wanting to do something in that space and help in some way. And but that got me to do the degree in psychology, and obviously I'm working in a few other places as a consequence of that.
You've really married, I think, all of your skill sets really quite nicely, which I think is something that doesn't necessarily occur to graduate diploma students when they come to study psychology. Sometimes, the aim might be to leave the previous career behind. But of course, you've probably picked up along your journey some really valuable skills and knowledge that can be transferred and married with what you're picking up in your graduate diploma. And who knows, maybe you end up in a space like Simon where you've really effectively brought those factors together and have started to make quite, I would say, unique contributions to the mental health space and the discussions that are going on, in a really influential way like Simon has.
And I've witnessed that with a lot of people that I studied with. I think the great thing about that graduate diploma, I'm loving looking at the past Chris that's still moving, by the way.
Oh no,
really? I'm really enjoying that. But I noticed that with the grad dip in general, there were so many people with such diverse skill sets that came into that one room, that we're all there from 9 till 5, that I'm sure a lot of you are in for MBB2 now. And some people went into, practicing clinical psychology, but they practiced it differently because because they're bringing those different skills. Some people came from a sociological background, other people had a marketing background, and that really complemented the way that they did clinical psychology. But then, I've got other friends who've gone on to do education and work in law and a range of different areas where they more explicitly kind of intersect between psychology and other disciplines. So yeah, I would just say whatever way you can, try to blend those experiences and sets of expertise together, including your lived experience. I think it's really valuable.
More and more students are coming to study psychology than ever before. In fact, I think our first semester enrollments are going well north of 2,000 just for Mind, Brain and Behaviour 1 this semester. Wow. And if the Dunedin mental health study is teaching us anything, it's that the old previously held assumption that around 1 in 5 people will experience a mental health problem in their lifetime isn't quite right. It's more like 4 in 5 of us who are going to experience a mental health problem during our lifetime. And particularly if you're interested in working in the mental health workforce, whether that is clinically or non-clinically, I think that gives you a really interesting personal context to work from. And I've certainly got my experience with anxiety and with certainly behavioral depression. Thanks, COVID. Good on you, COVID.
Winter, I found.
Winter. Yeah, winter can absolutely be a thing. And speaking of COVID, I think, in the context of COVID, probably the general public's awareness of mental health and discussion about mental health has probably been more prevalent than ever before, which is great. But of course, there are a range of opportunities for people to work in the mental health sector, whether they have lived experience or not. And it's probably not an all or none situation, right? Everything's sort of a little bit more or less, really, isn't it, in the mental health space than all or none.
Absolutely.
COVID's exacerbated my ping, apparently. So let me try and turn my camera on and off. Let's see what happens here. All right, we'll go down the rabbit hole here, and I'm going to try and restart my camera. And let's see what happens. Hopefully.
Hey, that's good. I think that's good. Can everyone else give a thumbs up to that? I feel like that was.
What do we think?
Well, then maybe now I'm late. I don't know.
Deary me. Anyway, if it persists, I'm just going to turn it off.
Yeah.
But and we'll put you front and center, Simon, and I can be the dulcet tone in the background. So
that's right. That's good.
So, Simon, you had a previous skill set, I suppose, that you could draw upon to open some doors for you in the mental health space. So, to work with Vimiac, for example, you had your legal qualifications and experience that you could draw upon to open some doors there. And something that our graduate diploma students are so interested in, and all of our so many of our psychology students are interested in how one can get experience in the mental health sector in some way, just to contribute and to test the waters and to experience what it's like. Have you got any particular recommendations that you might make for students who want to work either clinically or non-clinically in the mental health sector while they're still studying?
Yeah, I think we were just having a conversation off there, and you were talking about how you reached out to somebody, just recently to see if you could support in a voluntary capacity around something. And I just think being really proactive, so identifying what it is you care about. So for me, got that law and politics sort of, interest. So I sought out networks that kind of took me into that space. So I definitely reached out to to Vimiac. But then I remember I had to slog pretty hard to get that first job. And so I offered to volunteer at a range of different organisations, many of which said that they couldn't take me on for whatever reasons, capacity reasons, or that they don't take volunteer students. But ultimately, I think I built a network through doing that and through making those offers and having an eye towards obviously making that relationship reciprocal. So, what am I bringing to the table, and being really clear what I think I can bring to the table in that relationship. But then, you're going to learn a lot too. So taking an open or a growth mindset about how, you think you can learn and benefit from that organisation too. I would work on networks. Networks is the best way to do that. And so if you,
yes,
it might be different communities. So if you're, part of a particular cultural community, there might be ways in which you can bring your skills around mental health or psychology, clinical or non-clinical, into that space. So it might be, researching or giving some informal advice to a service or a community that might have issues of which you're part of. And so I think really broadly about that, because it's those skill sets that I think are, and networks that I think get you those first opportunities and an idea of where you can help.
It's such great advice. And in fact, I've seen this and been part of this process pragmatically today. Somebody through networking reached out to me and said, look, I imagine there's no opportunities, but, and, half an hour later, they've now got an internship opportunity that they didn't think existed. And so I think you're absolutely right. Making connections, keeping in touch with people, following along on, as much as I loathe social media, following along on social media keeps you up to date with what's happening. I probably learn more about what's happening in the Melbourne School of Psychological Sciences because it is so big. There's so many researchers all doing amazing things, and teachers doing amazing things, and students doing amazing things, that I follow along and I learn more on Twitter than, I would otherwise.
Absolutely.
You can follow along with, I think your experience is so unique because you've worked in the mental health sector in a way in which most people don't think is possible, and that's to work non-clinically. A common conception is, counsellor or psychologist or nothing.
That's right.
But you've carved out some really unique space with your work, and indeed, you've brought your legal experience, but since you've finished your grad dip, you've brought your psychological research experience as well to some incredibly impressive projects that you've taken on, like the Your Story, Your Say project, for example. Would you like to tell everybody about that project?
I mean, so this is back when I worked for a different organisation. I finished up there, but I used to work for a legal organisation. And the Your Story, Your Say project, it's something I'm proud of, but more importantly, I think the people who were part of it and sort of were the underpinning of that project are the people I think who should be most proud. But it was a project to assist. Ultimately, it was 34 people to give evidence to the Royal Commission into Victoria's mental health system. So, I'm sure a lot of the students are aware that, we've got a Royal Commission going on at the moment, and that the final report must be minutes away or days away, because it was due to be released prior to our lockdown.
As long as the tennis doesn't go into overtime or something like that.
Djokovic doesn't have some kind of party.
That's
right. And so I think a lot of there's a range of perspectives that are critical to improving our mental health system. But historically, the people who've been heard the least, and unfortunately, the people who weren't represented on the commissioners, so there wasn't a commissioner there, was somebody with a lived experience of mental health issues or having gone through the mental health system. And so the project was to assist 34 people from a range of different backgrounds to give evidence to the Royal Commission about in whatever way they wanted. And so for people, it was usually a storytelling process. And that usually took the form of, or could be pretty open in terms of form, but what happened to them, what they want the Royal Commission to know, and what they want the Royal Commission to do. And so those were stories in their own words, and it was really important that the Royal Commission and also the broader community hear some of those stories, because it's really different to the stuff that we hear often in mainstream settings, because these voices are often the most marginalised, and they're often within our clinical mental health system behind locked wards. So it was a powerful project, and that the report's publicly available. I'm happy to talk about some of the themes in that, but I would definitely encourage the students to have a read through that. It's very eye-opening if you're just looking to go into the mental health system in a clinical or non-clinical role.
Absolutely. And you just mentioned themes, and I was just thinking from a research perspective, where with the graduate diploma students who I assume are out there in the audience, I'm doing a good job this summer semester of trying to indoctrinate them into the quantitative world, where we assign numbers to everything and measure all sorts of psychological phenomena. Yeah. And it's going to be some time before they really get a taste of qualitative research. So whilst they've just been introduced to all sorts of, repeated measures, correlational, experimental, quasi-experimental designs and so forth. Are you able to talk a little bit about what qualitative research basically looks like? What sorts of, thematic analysis, I imagine, type techniques you might have applied to that? Data?
I think I can give you my graduate diploma graduated version of it. I think you would definitely be able to extend on what I'm talking about. I could say the process that we went through. So, critical to this was the idea that people with lived experience sort of tell their own story, and that was in their individual stories. But then when we wrote a report summarising the themes that came out of that we were doing justice to that. So there was 34 stories that went directly to the Royal Commission. Those aren't public. And in that report, we brought together the stories, and then we developed, I guess, a bit of a coding matrix. And so the way we did that was to see what themes came out of those 34 stories. So a group of us came together and read through a selection of the stories each. And we saw, I guess, tried to group together what are the key themes that are coming out of these stories. And from that, and on that group, there was people with lived experience. So, 2 experienced people working in qualitative research who come from a lived experience perspective. I have a lived experience, but my role in this project wasn't a designated lived experience role. And so from that, we developed, I guess, a bit of a coding matrix to about how I would then and other people would go through and analyze the whole, all of the stories together. And so that's where I guess we came up with 6 or 7 different really high level themes, and then there were sub themes about what do people want the Royal Commission to know. And usually that was issues, the issues that came up in the system. There were definitely moments of where people had good experiences. And then, the themes that came out of it in terms of what did they want the Royal Commission to do? So what changes did they want to make as a consequence to the experiences that they'd had in the system?
And some of the, many of the themes, I would say, that you were picking up in your survey were very similar to the themes that I was picking up in my own in the National Stigma Report Card survey at the same time. And for those who are unfamiliar with the National Stigma Report Card, this was a project, or is an ongoing project that's a partnership between SANE Australia and the Melbourne School of Psychological Sciences. And so my lab works closely with the Anne Devison Research Centre at SANE. The funding was generously provided by the Paul Ramsay Foundation, and we surveyed just under 2,000 people across the country who live with severe and complex mental health issues, and we asked them about their experiences of stigma and discrimination in 14 areas of life. One of those was the mental health system, and it suffices to say that quantitatively speaking, we saw really frequent experiences of being treated differently, being treated unfairly, and in the mental health system, and particularly if you had certain types of mental health experiences, borderline personality disorder being the prime example of a group that have there's just a volume of literature about how people with this experience receive discriminatory behavior treatment in the system. Now that's
or lack of treatment, right?
Or lack of treatment. Yeah.
It's a very different experience in my, what that's not my lived experience, but from having worked with people, a lot of people, depending on the diagnosis they're given, and I say that a lot of people don't identify with their diagnosis or with that approach in general, but it's about getting out of the system. And for a lot of people diagnosed with or identifying with BPD, they want to get into the system and they're being shut out from it. So it's a very different form of discrimination that I hear reported in that sense.
Yeah, absolutely. And we saw it across the mental health and just the general medical health systems as well, in terms of if you were maybe seen by and of course this is not a generalization, so by no means are we saying that all staff in the mental health and health systems are stigmatized against certain groups. By no means is that the case. Everybody, most people are, by and large, most people are there trying to do very good work.
But we've got systemic problems, don't we? Isn't that? So I mean, if we focus it on apples, we don't look at the card, or whatever the saying is there. That we've got a system that facilitates this kind of discrimination, and so for people to not do it, they have not discriminate as individuals. They actually have to work very hard against the system, and usually at a great personal and professional cost as well. To resist the way systems are structured here in Victoria, but also more broadly.
You just reminded me of, oh my goodness, who was it that said it? This was at the Themes conference, summer conference a couple of years ago, and I'm trying to remember who it was, but it was a chief psychiatrist from some state, and she opened her talk by saying, I have to acknowledge that I am an agent of an oppressive system. And that was just a really powerful way, I think, to acknowledge that inherent in any sort of system like this, there's a power issue, isn't there? Power certainly comes through as a really prominent theme, I think, in a lot of the feedback that we've both got in our surveys.
Yeah, absolutely. I think, from memory, and the stigma, our Turn to Speak report spoke about maybe 50% people getting treatment they didn't want or being unfairly treated in a mental health service. So I could be misrepresenting that, but I remember it being around half of the respondents spoke about that. And that's the discrimination and stigma frame is the one that you take there. But within the Your Story, Your Say report, the similarly themed was, people spoke about experiences of power and control. So I think it was over 80 or 85% of people who told their stories, and we didn't ask questions about this. We asked 3 simple questions, usually really open-ended questions, had themes that were about feeling powerless or feeling controlled by the system that they were in. And so, there's obviously systemic problems, and there's lots of micro expressions of that in little interactions and little parts of the system, but globally, it's obviously a big issue.
Yeah, absolutely. Speaking of power differentials in the system. Amy's asking here in the chat that a while ago she heard that Victoria uses more CTOs than any other states in the country, and why you think this might be.
Yeah, you're right, Amy. So I know that, there was a period of time, I think there was a 2013 study that actually rated us as some of, if not the highest in the world in terms of our use of CTOs. But definitely a more recent study in 2018 or 2019 spoke that we're definitely one of the highest within the country. And so for those people who don't know, a CTO, a community treatment order, allows someone to be compulsorily treated when they're in the community. So what that would practically look like would be someone is made to come into a clinic every couple of weeks to probably get a depot injection, which, an injection of some kind of antipsychotic medication, or that they take daily oral antipsychotics or mood stabilizers. And so why do we have such high rates of CTOs in Australia? I think in Victoria, part of a real basic thing is that people don't want to use our system, you don't have such high rates of compulsory treatment if you have a system that people want to access. And I think that's we don't have good voluntary community-based alternatives. We don't have systems that really engage with trauma. A lot of those clinics that people have to go to compulsorily don't engage in the kind of psychosocial forms of care that I imagine, certainly when I started out MBB 1 and 2, the kinds of care that you would assume people would get. Like people are quite amazed when they're sort of used in the negative term, that if in their first admission that they go into a psychiatric hospital or get some form of compulsory community care, that they don't actually really get to see a psychologist. And if they do, it's largely around psychoeducation, which could be about like, maybe behaviors to make sure they take their medication, or, dealing with some sort of minimal things around thoughts, but not really examining the meaning of their experiences, what's happened to them. So a lot of people, there's such enormous rates of trauma that underpin, people's experiences of mental distress. I remember DHHS putting a statement out a couple of years ago that, and I'm going to say the lower amounts, so that if I'm wrong, I've understood, but it was something like 70% of people within the clinical inpatient setting had some form of severe trauma, and so, but we don't deal with that in the system, and so people don't want to access it, and then they're made to access it forcibly, which traumatizes them, which makes them less likely to want to access it, which increases the rates of compulsory treatment. So we've got a really bad spiral downwards in the way that we have set up our systems. So, I certainly, that's not all of it. I think a lot of people talk about just general underspending. We don't have enough voluntary alternatives, and Mind Australia, Wellways, and also consumer and peer-led services that give people the support they need at earlier stages. That's a longer.
It is a long discussion, isn't it? We've got so far to go, and I suppose one of the first times that I really started to think about how trauma is experienced in the system was when, where are we? 2021. Good Lord. I suppose about 20 years ago, there was some really pioneering work being done by my PhD supervisor, Henry Jackson, and Pat McGorry around early intervention. And, some of the rationale was there that if we can identify people who are at risk, who are vulnerable to developing mental health problems, and we can offer some, low intensity psychosocial interventions that would prevent transition to, a more disordered way, a more disordered experience, then you avoid all of the trauma that comes with going through the system. But at that time, I remember thinking to myself, then as a student, why is the system causing trauma? Why do we have a system that causes trauma? Surely we can do something about that. And it sounds very, obviously we're talking about it very briefly and in sort of generalizations and simply here, and it's very complicated.
Yeah, there's more depth to everything that
There's
we're
more
touching
depth to everything. I mean, fundamentally, we need more system resources. We need more system resources. I think there's also a strong argument to be made for empowering the community to play a significant role as well.
Yeah.
I went to a really interesting talk a couple of years ago that really stuck with me. I think this was Simon Staffris. Was talking about the idea that maybe through the professionalization and the medicalization of mental health, we've sort of disempowered the community to feel like they can do anything to support people with lived experience.
Yeah, that's right. And we can get in a habit within. I mean, I stopped short of sort of training more clinically, but I definitely did a lot of therapeutic training to support my my practice as an advocate. So I used to advocate in psychiatric inpatient units, and so I did a lot of trauma-related training in that space. But we tend to get in in this space tricked into manualizing processes, in terms of therapeutic engagement. So just give me the manual for how I can help someone. So if they say X, then I say Y, and and so I think it does in turn. I mean, it means that you have to have access to that manual, which is part of that professionalization. So you need to go through the course to do that. But then I think it definitely strips away, I think, what is some of those innate abilities that we all have just to connect with someone.
Yeah.
To say that's shit that you're going through that, or I had a rough time with that too, or just sit and have a yarn with someone for a bit.
So there's probably space for layers, is what I think I'm hearing, is that, there's probably a space for, for us all to be able to exercise that, as you say, that just natural compassion and empathy that we have and connect with somebody who's having a difficult time. And, no doubt there's also a role for, people with advanced training and skills to apply those sorts of manualized, targeted therapies. But I suppose what we want is all of those things, don't we? Want all of those things and more. And that's why I think we're so keen to see what's going to come out of the Royal Commission report. Have you got a wish list of the things you're looking for to come out of this report?
I mean, they have to, the task is so big. So I think that for a Royal Commission, they've got a lot of people with a lot of wish lists. But definitely for myself and for a lot of the people that I've worked with and a lot of fellow members of the consumer community. A lot of it is around, having access to those early supports, but they don't have to just be, medical forms of support. We need, we've got a chronic, we talk a lot about underinvestment in mental health, but it pales in, says nothing of the underinvestment in peer support and, peer meaning someone with lived experience working with somebody who's experiencing crisis at the moment. So definitely more peer support, changing, I guess, the objectives of a tertiary mental health system. So certainly lowering or reducing the reliance that we have on it. It's a very tertiary or clinically focused system at the moment. Which means we kind of feed the beast by putting a lot more money into that, but it's probably not solving the broader problems. And so, change and as a consequence, that clinical system is really about controlling and managing risk, and that's why people's experience of the system isn't a therapeutic one, because they're really experiencing that power and control. So, trying to realign what we mean to do when someone wants to go into a clinical service. The other is to address those experiences of power and control. Compulsory treatment is, that's a pandemic in Victoria, and we need to flatten that curve too. It's so we need to my position is we need to build a system that doesn't rely on compulsory treatment, and so we need to put steps in place to do that, and we need to commit to doing that. So those are really the goals that myself and a number of other people want out of this Royal Commission, and we'll be eagerly awaiting whether the recommendations address that.
Yeah. It's such a tricky space. I've been on a journey around compulsory treatment, I suppose, over the last 10, 15 years, coming from a very clinical space and having worked in, large-scale national suicide prevention initiatives and services. It's frankly a scary space for me to contemplate. And I have little discussions here and there with. I think it's really important to not disregard the opposing view or the disrupting views in any particular debate, regardless of how contentious that debate might be. And what if we look right to the I suppose the extreme of end of this discussion, we're talking about the possibility of modifying the way in which large scale services and emergency services would work around suicide risk. And I think we both know people who would seek out professional support that would not intervene even if they express imminent risk of suicide. And that's a very uncomfortable place for me personally and professionally. Having governed large-scale services like the suicide callback service, and having lost people close to me from suicide. One of the fundamental, this is indisputable, the fundamental, science and evidence points to, reduce access to means of harm and people live. But how do you do that in a way and grapple with the power issues? I don't know. So,
I think I agree. And if anyone tells you it's a simple issue to solve, it's not. I think part of the issue is that, at least here in Victoria, it's very hard to see a system that wouldn't rely on it, because we are so reliant on it. The scale of our reliance on it, people talk about it. Compulsory treatment is the glue that holds this system together, and that's not a good thing. And so, if we commit to, eliminating the compulsory treatment, then we will lower it. And at the time that we dramatically lower it, then we'll be able to see what the next possibilities are. But the scale of the problem is so big at the moment, and people's aversion to accessing this system is so great at the moment, because we don't have the suite of services that people would want when they want it. And part of the other issue is that the system is a bit of a legacy system of the old of stigma and discrimination. So a lot of clinicians I talk to, eventually they'll say, but if I let so and so out and they go and commit a violent act, that's on me. And a lot of that is built on a really disproportionate assessment by the community of risk of harm, and and also linking mental health to bad behaviour sometimes too, when the link isn't there. And so I think there's a responsibility for us as a community to be able to sit in some complexity when some of these things happen, so that we don't drive risk cultures within services that that just contain people for fear of some kind of public indictment. So we've all got a role to play, I think, definitely.
Such an interesting point. We've been doing some work around this space, certainly around perceptions of violence, of people living with mental illness as these stereotypes of violence, and looking carefully at how TV news media, for example, might give rise to these sorts of perceptions. And one of my PhD students is just winding up at the moment and did a really interesting series of studies that sort of unpacked this and looked at really how decontextualized reporting and pairing of a violent crime and a diagnosis like schizophrenia, it just creates that pairing. And it's, there's no context. There's nothing about all of the other factors that are more likely to explain what has happened.
I mean, male violence towards females. Gender is a huge driver of violence, but we often don't talk about that. Or Y chromosome's a pretty good predictor.
Absolutely, and a whole range of other things as well. The problem is that we did a review of all of the newspaper reports of schizophrenia in a certain period of time in Australia, and found basically no positive reports. Very few. All just systematic. There's a strong systematic bias in news media reporting. Anna Ross at Melbourne Uni, the School of Pop Health, does some great work around this. She's a PhD student as well. And as psychologists, as mental health workers, we're all still members of the public, and we're all still saturated by these news stories. And I've done some work with some students recently, looking at the relationship between the types of stereotypes and attitudes and prejudices that we might hold in personal life, and how that can bleed into clinical practice and so forth.
I think there's a lot of parallel processing that can go on.
Oh, absolutely. It's such a thing, and something we have to be vigilant for. But thankfully for the mental health workforce, I think one of the best ways, the best thing is that they're generally participating in a contact-based stigma intervention, where you're working with people with lived experience on a daily basis, and they're not hurting you. They're just like you and I. They are you and I, and they're having a rough go of it.
Yeah, that's right. Yeah.
We've got some more questions here.
Well, the one thing I would add to that is just on that media reporting. I think there was an example earlier in the year last year. All the years blurring together. Around linking, mental health and violence. It was a Four Corners report, and I think there's a lot there around the linking of violence to mental health diagnoses. But for me, one of the huge glaring absences in that whole story was that there was nobody with lived experience who was interviewed as part of it. And so I think that's a really good example of stigma and discrimination, is the exclusion of people from these conversations. Never get away with having an all-male panel. I'd hope so. On this day and age, on the ABC, having an all-male panel discussing, female-related issues, or an all-white panel discussing race. But in mental health, we still really we've got a long way to go in these discussions about letting people speak for themselves. And if we did have, people with lived experience interviewed in that, they would have a range of perspectives. But what they would definitely talk about is, just going into an inpatient unit or getting clinical mental health care isn't necessarily the solution for them, and that they've actually experienced a hell of a lot of violence within the mental health system, in particular because of our reliance on compulsory treatment. So definitely we need to make sure, if you see a news report or you see somebody talking about mental health or something that impacts people with mental health, just turn your mind to whether those people are represented in that discussion.
Absolutely. And if you do see something that you think is concerning, then you can certainly contact Stigma Watch, which is an initiative run by SANE that works with journalists and so forth to monitor and improve, I suppose, journalistic practices around reporting mental health. And you're right. I think you know my feelings about lived experience. I think it's just so valuable that we include the voices of lived experience in everything that we do. And I think when I think about my time in the mental health sector, we've come a long way in the last 10 years. No doubt there is still a long way to go, a frustratingly long way to go. But 10 years ago, the idea of co-design, I've sat around tables, with colleagues laughing at the idea of co-design, co-designed research or initiatives. But I think there's a growing momentum, and certainly when we think about basically the saturation of consultation in the sector that occurred over the last couple of years, one of the strongest themes that came through was that lived experience, needs to be at the center of any sort of systems reform. So let's hope that when these findings land and action starts to manifest, that we actually see that translate.
Yeah, absolutely. Oh, there's some good questions, Chris. You've got a great cohort.
Yeah. So there is a question there that. So let's see. Let's have a look here. So Hamish has asked what a typical day looks like for you. So maybe, given that we're running close to the hour, maybe we can wind down by changing tack a little, and given that you are the star of the show today, asking you, pragmatically, what does a typical day look like for somebody who works in the mental health space but not as a psychologist?
So I'm doing consultancy now, so that's where people pitch work where they need some advice on something, or training, or supervision around things. But maybe to give you an example of a prior job that was really informative for me, I used to do advocacy for people in inpatient units, and so that's where someone was on a compulsory treatment order, either actually in the community or in an inpatient unit. They would contact the service that I used to work for, and it would be a free advocate myself, and I would work on their instruction. So I'd be their advocate in the sense that I could support them to advocate for themselves, or I could communicate their views and preferences on their behalf. And so I would go into I've probably been in 2/3 of the inpatient units here in Victoria, and I'd go into one of the metropolitan ones, and I would meet with a bunch of people on the ward, and I'd say, hey, you might be on the Mental Health Act in here compulsorily, but you have rights. You've got the rights to, have your informed consent sought, to be supported, to make your own decisions, even if you're under the Act, that your broader recovery, so the broader things in your life that you want to be respected and honoured, those things need to be part of your treatment. And usually people would say, well, that's not happening. And so, if they wanted, I could provide, information about how they could communicate with their treating team themselves, or they might ask me to then go into meetings with their treating team. So then I'd go into a meeting with the psychiatrist and the rest of the treating team, and we'd have a conversation about, well, what are the things that, if it's Chris is the consumer, these are the things that Chris wanted, these are his rights, and we would talk through, I guess we would talk through and try to get the outcomes that Chris was looking for in that circumstance. Very tricky role, because it's a system that doesn't necessarily operate according to people's rights. And like you say, Chris, people are trying to do their best working in that system, and so it's there's definitely different sort of focuses, or I guess ideology isn't the right way to put it, but the different cultural approaches around that. But then there's also a failure of higher systems planning that kind of puts an advocate and a clinician in a really contrarian situation, and a consumer, because consumers legitimately want things that the system is just not set up to deliver. And those are things that we should all expect, basic human rights and dignities. So it'd be like that, and then I'd work with someone for upwards of a year to because some people can be on community treatment orders for 10 or 11, sometimes 15 years. So yeah, that would be like an example of a day in an inpatient unit, and I could be there for 5-6 hours talking to different people in that space. So
and have you found, so you've had, I think some incredible experiences. Do you find them? Do you find it valuable, the experience, gratifying? Do you like the work? Find it satisfying?
Yeah, absolutely. I think for me, it's the connection of social justice to mental health. I'm really fortunate. I haven't experienced involuntary treatment myself, but I certainly know that the intersection of those things and addressing those problems is what gets me out of bed. And I know for a lot of you, it'll be, you'll have a connection between psychology and something else that matters to you. And I think when you find that, it becomes pretty obvious that you want to work in that space for a long time. Doesn't mean it's not taxing, and it doesn't mean I don't have days where I spit the dummy and say I don't want to do it anymore. As I'm sure everyone working in the system does. Yeah, you'll all have a chance to spit your dummy if you haven't already. But yeah, no, definitely big time. I'm into it.
I think that's a great place to finish up. I'm really encouraged by, like, sincerely, by what I've seen you accomplish in your time since you've started and finished a grad dip, and I'm really encouraged for all of the different people that are out there watching you right now who are going on with the grad dip and have got different life experiences and circumstances and different interests and probably quite some diverse intent in terms of how they might work in the mental health space. And so I find that encouraging. The more we wrap around and all with that common goal of improving outcomes for people with lived experience, I think the better things will be. So I think that's a great place to call it a day, because I think, is your cat coming at you? Are we getting cat?
Yeah, no, yeah. He did jump onto my lap earlier, but he's subsided. But I am keeping my eye on him. You might notice. Yeah.
And so everyone out there in the chat, I hope that you found this first session to be helpful. And Simon is the first person that I've asked to come and speak with me on what's going to be a series of discussions where we talk about things like opportunities in the mental health system for experience. We talk about important topical issues and give you guys a bit of a flavor of what sort of opportunities and issues are out there in the system at the currently. And so I think one thing that you can all be doing is keeping your eyes on the report coming out from the Victorian Mental Health, the Royal Commission into the mental health system.
And if you haven't already, have a read of Chris's. Chris is a bit of an expert in the space. He probably wouldn't say, but he did a witness statement on stigma and discrimination in 2019. So you can find that on the Royal Commission website. It's definitely worth a read, and it's a good summary of all the evidence in that space. So
I've been outed.
He wouldn't say that, but I would recommend that you read that.
Oh, brilliant. No, well, look, I was just about to ask Simon how people can follow you. What's your Twitter handle? Because you're quite active on Twitter about your cat and other things.
Yeah. I'm definitely, as we speak, I'm like, what? That's a great question. So my Twitter handle is just Simon Katterl. Yeah, so you can find me on there. So I do a lot of my, I put a lot of my information about consulting up there, but a lot of information on mental health, and I think you'll probably find I share a lot of perspectives from people in the consumer community who, have lived experience, and that's a good connection to learn about what they're doing as well. So, jump on board and drop a line privately on a message if you want to have a yarn too.
Fantastic. Okay, everyone, thank you so much for joining in. I'm going straight out to buy a new graphics card for my computer. And
Yeah.
I will see you all in the next one. Take care, everyone.